It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the PainExam Podcast. This is your host, David Rosenblum, and the NRAP Academy is focused on board prep, regional anesthesia, and ultrasound guidance. We prepare you for the ABA, ABPM, and ABIPP, as well as the FIPP examinations. Before we get started, I wanted to invite you guys to attend ASPN this summer in July. It's in Miami from July 16th to the 19th. I'm running the ultrasound and regenerative medicine course with Dr. Ali Vali Moed, and we have an all-star faculty. We're going to review ultrasound training for various body parts, as well as regenerative procedures such as MFAT, BMAC, and of course PRP. We also have Pain Week coming up, where I will be lecturing with Dr. Ryan Budwani on AI and robotics in pain management, as well as lecturing with Stephanie Vanderpool on image-guided pain procedures, fluoroscopy, ultrasound, etc. It's going to be a great talk and great conference, and I hope to see you guys there. In the meantime, we have ultrasound courses coming up monthly in New York, as well as in Costa Rica and elsewhere. I'm going to be doing a series of courses in Costa Rica, so if you're interested in coming, reach out to me. Look at the NRAP Academy website at nrappain.org. We post the shows. If you have a group and you want to arrange a group course, myself or one of my instructors can meet you down there, and you can make your Costa Rican trip an educational experience as well as a business trip. So, today I'm going to focus on some board prep topics and some topics that might just be applicable to your day-to-day pain practice. The first is SI joint dysfunction, and this is always tested on the board, and you'll see this in the office. SI joint pain accounts for 15 to 25% of chronic axial low back pain cases. The sacroiliac joint basically forms the keystone arch that bears the weight of the upper body. These ligaments can become lax or injured with stress or with pregnancy, and the joint is synovial, has ligaments covering it. Sometimes it's not really just a joint itself that becomes arthritic. You can have ligament tears. The innervation is complex. It involves the dorsal rami from L4 to S3. And the pain may result from joint inflammation, degeneration, hypermobility or hypomobility, trauma, or pregnancy. In addition, this joint is typically stressed in patients who have adjacent segment disease, so if there's a lumbar fusion, the pressure and weight will translate down, especially if they're fused to the sacrum. More stress will be translated to the sacroiliac joint, predisposing these patients to pain. The provocative maneuvers include Faber's tests, Gainsland's tests, the thigh thrust tests, the compression and distraction tests, and Medicare is now requiring a significant number of these tests to be positive prior to paying for a sacroiliac joint injection. In addition, you need to have a diagnostic injection prior to performing a therapeutic injection. The diagnosis is clinical. It's confirmed with image-guided sacroiliac joint injection. It's not really confirmed with an X-ray, MRI. Of course, you should have imaging prior, of course, and to rule out other problems. Conservative care is physical therapy and NSAIDs. Interventional is sacroiliac joint injections, radiofrequency ablation of the lateral branches, which happens to work very well for these patients, but unfortunately is not covered by Medicare at this point in time, and fusion of the SI joint. So, board pearl for this problem is that you diagnose it with an injection, not with imaging. Which of the following best confirms the diagnosis of sacroiliac joint pain? A, MRI findings. B, CAT scan findings. C, physical exam maneuvers. D, image-guided SI joint injection. E, X-ray. D, SI joint injection with local anesthetic confirms the diagnosis. I just mentioned that earlier. Here's another board prep pearl, or question, I should say. How many provocative SI joint tests increase diagnostic accuracy? Well, the more the merrier, right? They give you options of 1, 2, 3, 4, 5. The answer is 3 or more provocative maneuvers suggest SI joint dysfunction. Now, moving on, phantom limb pain is another high-yield topic that's tested on the boards. Phantom limb pain is a neuropathic condition experienced after amputation and is a classic high-yield topic. It's distinct from phantom limb sensation and stump pain. Once again, stump pain is just pain at the stump. That's what it sounds like, right? Phantom limb pain, you actually feel like you have the limb still there and it's painful. There's peripheral nerve injury and neuroma formation typically, central sensitization with cortical reorganization in the somatosensory cortex, loss of inhibitory input, presents as burning, cramping, electrical pain in the amputated limb, intermittent or constant pain is present, and it may be triggered by stress or weather changes. Important distinctions that phantom sensation, there's non-painful awareness. The phantom pain can be perceived quite painful, and the risk factors include pre-amputation pain, traumatic amputation, poor perioperative pain control. Medications to treat this problem include gabapentoids, tricyclic antidepressants, NMDA antagonists such as ketamine, mirror therapy and cognitive behavioral therapy on non-pharmacologic treatments, and peripheral nerve stimulation, spinal cord stimulation, and DRG, dorsal root ganglion stimulation, are all methods used to treat the pain. Board-style questions. Which mechanism is most associated with phantom limb pain? A, muscle spasm. B, cortical reorganization. C, joint degeneration. D, ligament injury. E, sympathetic overactivity only. The answer is B, cortical reorganization. It plays a major role in phantom limb pain. Which therapy is effective for phantom limb pain? A, epidural steroid injection. B, mirror therapy. C, sacroiliac joint injection. D, facet block. E, trigger point injection. The answer is B, mirror therapy helps retrain cortical representation and reduce phantom limb pain. There's no mention of lumbar sympathetic block or sympathetic or stellate ganglion block here in this review I did, but that is something you could consider for these patients, and you may get some benefit. Anyway, I hope this helps you out for the boards. If you're looking to prepare for the boards, go to nrappain.org or painexam.com. Once again, I look forward to seeing you at the courses. We also do ultrasound shadowing at one of our locations where you could come and watch ultrasound procedures, or you can arrange an ultrasound course if you have a small group of colleagues, and you can set a date and time. Just let me know. Me or one of my instructors will come and meet you. Thanks for listening. Please share this with your colleagues, and good luck on the boards.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.